Hello everyone, today we'll be discussing hypokalemia. Hypokalemia is a common electrolyte disturbance that is often overshadowed by hyperkalemia. This condition is associated with cardiac disease, renal failure, malnutrition, and shock, with additional risk factors that include hypothermia and increased blood cell production. Prompt diagnosis and treatment are crucial to prevent severe complications. Hypokalemia is classified according to severity. A serum potassium level of 3 to 3.4 millimoles per liter is classified as mild. Potassium levels of 2.5 to 3 millimoles per liter is classified as moderate. And serum potassium levels less than 2.5 millimoles per liter are classified as severe. Symptoms of hypokalemia vary depending on the severity and underlying cause, but they commonly include muscle weakness, fatigue, cramping, palpitations, and constipation. Severe hypokalemia can lead to life-threatening complications such as fatal arrhythmias or respiratory muscle paralysis. Diagnosis involves clinical history, physical examination, and lab tests that include serum and urine electrolytes and ECG. On an ECG, as you can see on the diagram, you're going to see a prominent U wave, decreased T wave amplitude, depressed ST segment, and a prolonged QT interval. Initially, in the early phases, you may see T wave flattening, which is followed by ST depression and U wave emergence. PR and QT intervals may also be prolonged. Then, under serum electrolytes, you check for potassium levels, magnesium, calcium, and chloride levels. Causes: hypokalemia can result from decreased potassium intake, increased intracellular uptake, or increased potassium losses. So when we talk about decreased potassium intake, this is usually poor nutrition or dietary restrictions as well as eating disorders. Then increased intracellular uptake is usually due to insulin injection or beta-adrenergic inhalation. Increased potassium losses can arise due to excessive sweating, loop diuretic intake, renal disorders, diarrhea, vomiting. Pathophysiology: potassium is vital for cellular function, muscle contraction, and nerve transmission. So when there is low potassium levels, these processes are disrupted that lead to muscle weakness, arrhythmias, and other complications. Treatment of hypokalemia: so this involves potassium replacement tailored to the severity of hypokalemia and addressing the underlying cause. The therapeutic goals for hypokalemia are to prevent or treat life-threatening complications, correct the potassium deficit, and address the underlying cause. Therapeutic urgency depends on the severity of hypokalemia, the existence of comorbid conditions, and the rate of decline of serum potassium levels, that is, how fast are the potassium levels going down. Potassium replacement is indicated in most hypokalemia cases, especially when renal or GI losses are significant. Concomitant hypomagnesemia should also be corrected if present. Potassium replacement alone may be ineffective if hypokalemia occurs concurrently with hypomagnesemia. Mild to moderate hypokalemia may be asymptomatic, thus repletion is often not urgent in such cases. So this is usually treated with oral potassium supplements providing 60 to 80 millimoles per day. Over days 2 weeks is usually sufficient. Replacement therapy must be provided rapidly when severe hypokalemia or clinical symptoms are present. Potassium chloride of 40 millimoles given every 3 to 4 hours for 3 doses is preferred. Rapid correction is via oral intake. IV administration or both IV administration is preferred in the presence of cardiac dysrhythmias, digitalis toxicity, and recent or ongoing cardiac ischemia. Prevention and management: preventive measures include dietary adjustments, managing medications, and monitoring electrolyte levels. An interprofessional team approach involving physicians, nurses, pharmacists, and dietitians is key to effective management and improved patient outcomes. That's all about hypokalemia. Thank you.